Good afternoon. The following talk was given at the Golden Circle of Excellence conference in New York City in 2014. My topic today is Precision Matters: How Cone Beam CT is Changing the Way We Move Teeth. My name is Jeffrey Miller. I graduated from the University of Maryland Dental School. I did my ortho training at State University of New York in Buffalo, and I have been treating with lingual appliances since 1983. There are really two discussion points I'd like to emphasize during my talk today. One is what separates us from the GP orthodontic providers, especially when it comes in the Invisalign arena, and how Cone Beam CT is changing what we do as orthodontists. Then I'd like to review two incognito cases to demonstrate those two principles. What is the bottom line? What does Cone Beam CT provide that cannot be obtained from any other radiological source? It's all about the boundaries. It's the bony boundaries that are created from the buccal and lingual cortical plates that can be seen on a tooth per tooth basis using Cone Beam CT. If you take a look at the image on the left, this is a traditional cephalometric X-ray using a 77mm focal trough. When you slice that down to a 0.2mm focal trough, you eliminate all the superimposition of the various structures to get a clear view of the bony support related to that lower central incisor. These images are both of the same patient. This is what's referred to as orthodontic boundary violation. Both these images are the same patient. On the left is the reconstructed cephalometric X-ray. If you were to trace this X-ray out and do the measurements, everything would look completely fine. The teeth might be a little procumbent, but the bone root relationship would not be alarming at all. When you take it down to a 0.2mm slice of tooth number 26, you can see that clearly this tooth has been moved out of the bony support of the alveolar process. With Cone Beam CT, you can visualize teeth from all three axes of space, from the sagittal, from the coronal, and the axial, and can evaluate the bony support for each tooth on an individual basis. You can't do that with any other radiological source. The reason that's important is because if you move the tooth through the cortical plate with orthodontic forces, you're going to create dehiscence and fenestration. Bone does not grow or remodel at the cortical plate. If you remember back to your physiology course, you have osteoclastic activity on the compression side, and you have osteoblastic activity on the tension side. If you put a buccal or lingual force on the tooth, the leading edge of that root is under compression. You only get osteoclastic activity. It's not realistic to think that just because you're using a special appliance or a light wire or whatever, that osteoclastic activity changes to osteoblastic activity. So how does this change the way we treatment plan cases? Well, up till now, most of the argument regarding one treatment modality or the other is based on long-term stability of our treatment. Boundary violations have not been a substantial part of the orthodontic debate, mainly because they couldn't be seen until Cone Beam CT. There was no way of visualizing how much bone supported a tooth before Cone Beam CT came. Sure, you could surgically flap the tissue, but by then it was too late. When does a boundary violation become a clinical concern to the patient? Well, it's clear that the tooth can withstand a certain amount of dehiscence or fenestration before there's a clinical problem. But where that threshold is unknown today. These photos were taken 15 years post-treatment. Patient came in because she had a broken lingual retainer. If you take a look at the reconstructed pan and ceph, everything looks completely normal. You certainly would not think there is any problem with the bone support to the lower incisors by looking at that cephalometric x-ray. But when you look at a clinical photo of this patient, she has generalized tissue stripping associated with the lower incisors. Now, is this a result of a boundary violation or a thin gingival biotype? I would suggest that the patients with the thicker gingival biotypes just hide the bony defects better. But if you look at her cone beam CT of tooth number 26, you can see that clearly there is no facial bone in front of the root of that tooth. And when you compare it to the reconstructed ceph on the right, you don't get any indication that this is the situation over here with that tooth number 26. Also, the mechanics we use make a difference. We don't know the long-term effects of round tripping teeth, especially when it comes to the lower incisor region. And also, we need to consider the path the tooth needs to travel to get back to its final destination. If that transition has the possibility of destroying more bone, that's probably not a good situation. And it can be better evaluated using cone beam CT. But for sure, additional studies need to be performed so that we better understand the relationship between boundary violations, root position, and attached gingiva. So how does this all change the way I treatment plan my cases? Well, I don't take a cone beam CT on every single case. At this point, I probably should, but I don't. I take a cone beam CT when I feel there's a clinical decision that can benefit from a cone beam CT. I can take the DICOM file created by the cone beam CT and upload it to Orometrics software, and using Orometrics I can simulate treatment, and with that treatment simulation I can see the final positions of the roots, how they relate to the bone. Once I get a simulation that I feel is acceptable, I can give the lab exact instructions on how I want that case treated. It's more precise, it's more precision. Now, a virtual simulation using a cone beam CT is completely different than a lab setup. With a lab setup, there is no consideration for the root bone relationship. All they are is manipulating the clinical crowns of the teeth. Now, I've done hundreds of these lab setups. They all come back looking great. And you can tell the lab, do not increase the lower intercuspid width, and the model will come back with no change to the intercuspid width. But you have no idea where they've repositioned those lower incisors. They could be completely out of the bone. You just have no way of knowing. So what makes us specialists as orthodontists? What differentiates us from the general dentist that's providing his own Invisalign treatment in his office? Well, I think there's two major things. One is that orthodontists are aware of the bony boundaries of the arches and attempt not to violate those bony boundaries. Also, long-term stability of the treatment is something that orthodontists are much more aware of than the non-specialists that are doing orthodontics. This case was referred in by one of the general dentists down the street who was having trouble with the case. It's a 49-year-old female. First thing I did is I went into ClinCheck and to check how they had treatment planned this case. Now, it was interesting that this general dentist used Invisalign Assist to help him treatment plan the case. And all they did really within the 15 trays was a little bit of arch expansion. They just took the lack of room and expanded it to a wider radius. Here's the superimposition of the original malocclusion with the virtual result. And this is a 3D reconstruction using Orometrics software. So what I did, I simulated treatment to try to mimic what Invisalign had recommended. And you can see the superimpositions using ClinCheck and Ormetrics. You can see I got them pretty close. Here's the Ormetrics virtual result of the lower arch. You can see all the roots are parallel, and this looks really good. It looks good until you put the bone layering on. When you look at the bone layering, you can see that these teeth were pushed almost completely out of the bone. Now, even though this does not show the changes to the interseptal bone, it gives you an indication of what you don't want to do. And I'm not suggesting that this virtual simulation is going to be exactly reproduced in the patient's mouth, but this is way more boundary violation than those teeth could actually withstand. If you take a look at sagittal view, this patient lost about 60% of their bone root coverage to that tooth. I also simulated the case using an aggressive interproximal reduction scheme, but this would be very difficult to do without round tripping the teeth. I mean, it certainly looks better than not using the interproximal reduction. And then I simulated treatment using one lower incisor extraction, and to me this looks the best. Considering the underlying bolt discrepancy, this plan worked out the best, and it was the least increase in boundary violations of the three choices. Also, you can evaluate the treatment simulation from the lingual. You can perforate through the lingual cortical plate just as easily as the facial cortical plate. The two incognito cases I brought with me today are both very, very similar. They're both hybrid cases where we used incognito on the upper and traditional appliances on the lower arch. First case is a 29-year-old male. He has a bolt discrepancy. He's class 1 on the left, class 2 on the right. You can see from the upper right cuspid that there is tissue stripping associated with that tooth. So I took a cone beam CT, and you can see he has generalized dehiscence on the upper anterior teeth. Now, clinically, I knew I was going to extract one lower incisor because of the bolt discrepancy. What I didn't know was how compromised the upper right cuspid was, that maybe I should consider extracting the upper right cuspid versus the upper right first cuspid. And you can see it, do you extract tooth number 5 or tooth number 6? Take a look at the cone beam C of that tooth. I don't have time to go on how these measurements are derived, but the cuspid has about a 62% total root bone coverage. That means 62% of that tooth's root is covered by bone, versus the first bicuspid, which has about a 52% total root bone coverage. Now, considering the root of the cuspid is longer, there's a substantially more bone around the cuspid than the first bi. But you also need to consider the path that tooth number 6 needs to travel to get back to the class 1 position. If you look at the axial view, you can see that there's plenty of nice bone there, so that retracting this tooth back into a class 1 position should not be a problem. I also want you to notice the contours of the alveolar process related to the lingually positioned lateral incisor. You see how the bone dips in right here. Here he is after 3 months. Now, imagine if you used the technique that advanced these teeth so that you could capture the wire in the slot. You can use with using stopped nickel titanium wires or open coil springs on a patient that already has generalized dehiscence. That can't be good. Here's a patient after 10 months. We got the bracket, the lateral engaged, the cuspid's back in class 1. At 11 months, I took a limited view cone beam CT to see where that upper incisor is. Make sure it's over bone. Here's the axial view, and you can see where that dip in the bone, if you remember the little dip in the alveolar process, there is a little bit, that root is starting to dehiss through that bone. You also notice that it's dehissing a little bit through the lingual, probably when tipping it forward caused a little dehiscence. And here it is from the sagittal view. You know, perhaps if I had to do this over again, I would have a periodontist add some additional bone prior to orthodontic tooth movement. Next case is a 60-year-old woman. It's also a hybrid case, very similar. She's got a lingually locked upper right lateral incisor, and she's missing a bunch of posterior teeth. Now with this case, I didn't start the bottom arch with appliances until significantly into the treatment. There was not that much work to do on the bottom. Most of the work was to do on the top. Here she is after 3 months of treatment. We're just trying to make space so that we can bring this lateral incisor forward. Now, I don't know how many of you have tried using the self-ligating lingual appliances. It's very difficult to do a case like this with the self-ligating appliances. They get in the way. They're cumbersome, I find. Here she is after 4 months. After 5 months, we're starting to develop a little more space. At 7 months. At 9 months, I placed the brackets on the central and the lateral incisor. But I did not engage fully engage the upper right lateral incisor until 14 months. Here she is at 17 months. At 27 months. At 30 months, I took a limited view cone beam CT to see where the position of that upper lateral incisor was relative to the bone. And you can see that that lateral incisor is in good bone, so I was happy with that position. Also notice there's a little bit of apical root resorption on the tip of that root. You can't see that from the reconstructed Panorex. You can only see that from the cone beam CT. If I had to guess, probably the tooth tipped forward and that root tip hit the bony cortical plate on the palate. You either get the bone to resorb or you get the root to resorb. It's one or the other. And she is the day we took the braces off. This is 31 months into treatment. It was a long case, but I think considering what she started with, it's a fantastic result. There's before and after. So do I think cone beam CT is part of the future of orthodontics? I absolutely do. I think it renews our appreciation for the bony boundaries that our patients have, and it also really differentiates us from the GPs providing orthodontic treatment via Invisalign. Because once you treatment plan a case to stay within the bony boundaries of the arch, the treatment plans become much more sophisticated and the mechanics become more complicated. And I'll leave you with one of my favorite quotes as it relates to cone beam CT. You never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. And that's from Richard Fuller. And I think that's exactly where cone beam CT is. The days of taking cone beam CT only to recreate the two-dimensional pan and ceph are over. The value of cone beam CT is to be able to look at the bone-root relationship of each tooth individually. I'd like to thank you for listening. If there's any questions, you can email me at ortho606@gmail.com. Thank you so much.